Perfect. All right, we'll go ahead and get started since it's 11. Can people hear me okay? All right, wonderful. Thanks so much. So I'm Nicole Nato out of Mass General Hospital, presenting today with my colleagues, Dr. Lynn Mortori from UCSF and Dr. Lee from Stanford. And we're going to talk to you today about some predominantly practice-changing, and we'll say maybe just some thought-provoking. It's a mix, research in pediatric emergency medicine, synopsis of the best new papers in 2024-2025. We know how difficult it is even for us as a mix of EM and PEDS sort of path, PEM boarded certified physicians to keep up with the literature. Never mind if anybody in the crowd doesn't sort of see kids as their primary focus. And so we were hoping this might serve as sort of an easily digestible resource in which we can sort of feed you what might be the most interesting new literature at the last 12 months for your consideration. And so here we go. We have no disclosures. All right, our learning objectives, as I alluded to already, we're hoping that by the end you can describe new practice-changing articles, as well as a few additional thought-provoking ones, in PEM literature from the last 12 months, essentially from last year's SAEM. Demonstrate the ability to critically appraise this literature and incorporate it into your own practice sort of as you deem appropriate. All right, so we'll start off with this guideline from the American Academy of Pediatrics. Regarding opioid prescribing for acute pain management in pediatric and adolescent patients. And it is fairly groundbreaking in that it is the first ever creation of a CPG for this topic in patients less than 18 years. It basically is a large group of experts that undertook a review of all pertinent randomized controlled trials, as well as high quality observational studies, with deference to expert consensus in areas where high quality data was insufficient. With this, they created 12 key action statements, which I'll try to distill down for you. 1 and 2 essentially said, avoid isolated opioid therapy. There's probably not many situations in which we shouldn't at least be trying to optimize NSAIDs, Tylenol, distraction, non-pharmacologic options, et cetera, and certainly potentially in addition to opioid therapy if needed, but we should try to use opioid-sparing therapy as much as we can. Key action statement 3 is at least consider immediate release formulation at the lowest appropriate dose for age and weight and limit that to a less than 5-day supply. 4 to 7 basically were all surrounding how much they just would like to dissuade us all from use of tramadol and codeine. It's a slightly softer recommendation for all pediatric patients, but a strong recommendation for those under the age of 12 with obesity, sleep apnea, lung disease, that are post-TNA or that are breastfeeding, and really related to this very unreliable and variable pharmacokinetics. And so some patients may have unexpected adverse events, some patients may have wildly insufficient pain control, and just not optimal agents. Action statement 8 is, of course, as we all know, just to use caution with other sedating medications. 9 is to consider providing naloxone, to consider making it a practice pattern that when you prescribe opiates, you at the same time at least offer a prescription for naloxone. 10 is to consider education regarding safe storage and observed administration. I think they know that all of our time is limited in the clinical setting. We need to sort of choose what guidance we can give, but this one was at least consider that discussion of should this be locked, should the teenager be sort of monitored in their taking of it with their broken wrist for the few days, et cetera. The next action statement was a stronger recommendation. They really felt like this was more of a mandate, something that they really did think was standard of care, which was to educate regarding safe disposal following that acute need. So once the acute pain of the broken wrist or the post-op period, for instance, is over, the need to make sure that's removed from the house and not sort of be left around without monitoring for future potential recreational use. And finally, their last action statement was to consider involvement of patients' outpatient prescribers and or pain palliation specialists when treating acutely worsened pain in patients with chronic pain. We, of course, know this can be a luxury that may or may not be available depending on your care setting. If it is, can be of benefit. So really the take-home points mostly is just awareness that there is now an AAP-sponsored guideline to assist with the safe prescription of opioids and some potential best practices to consider adopting from it as a helpful tool to let us give effective and equitable analgesia while trying to reduce our role in sort of risk of creation of opioid use disorder in our adolescent patients. All right, sticking with the theme of opiates, coming on to this study, which was a look at the efficacy and safety of intranasal fentanyl in pediatric emergencies. was a meta-analysis of RCTs evaluating intranasal fentanyl in pediatric patients with acute pain as compared to other agents, which predominantly were other IV opiates or intranasal ketamine. They looked at pain control at 15 to 20 and then 30 to 60 minutes, as well as adverse events of nausea, vomiting, dizziness, and hallucinations. There are 8 RCTs involving about 800 patients. They showed that pain control with intranasal fentanyl was superior at the 15 to 20 minute mark, not different at the 30 and 60 minute marks, and that there overall were less adverse events with lower relative risks of nausea, vomiting, dizziness, or hallucinations. And this isn't that groundbreaking. It's our somewhat anecdotal experience that some providers may have hesitation with use of intranasal fentanyl or lack of familiarity, and some parents even will sort of hear the word fentanyl and need reassurance that this is in fact well studied, safe, approved, and appropriate. And so this just gives us all that bit of sort of data to reference that it is a helpful option, particularly in patients who perhaps are younger that come in acute pain and whom getting an IV would be, a time-consuming to do. All right, we're going to move on to a bit of a trauma focus now, and I really like these next few studies and think they're really quite worth knowing about. So this is a study on the emergency department evaluation of young infants with head injury. And for anyone familiar with PCARN, you may recall that the PCARN decision rules are sort of broken into over 2 and under 2 years of age. But I think there is a large feeling sort of clear within that manuscript and just in the community that, of course, all under 2-year-olds are not sort of created equally in terms of their risk of head injury. They, in their sort of spot where they tell you to observe versus image, one of the factors that they say to consider is age less than 3 months. And I think we all have a sense that these patients can be somewhat more vulnerable, including NAT risk. And so this study really helps to quantify what is that difference, how much do we consider age as a factor. All right, this is a large database study using the Pediatric Health Information System, or PHIS. It looked at children less than 2 with isolated head injury by ICD-10 code across 47 EDs over a period of about 5 years. They compared patients less than 3 months to those 3 to 23 months, stratified by subsets of age of 3 to 5 months, 6 to 11 months, and 12 to 23 months. Their primary outcome was the use of diagnostic cranial imaging. And the secondary outcomes were the diagnosis of traumatic brain injury, clinically important traumatic brain injury, as previously defined by PCARN, or mortality. All right, so they found about 110,000 ED visits, with about 9% of those being in infants less than 3 months. They found that infants less than 3 months had a statistically significant higher rate of all outcomes compared against all other age groups, with the one exception being comparing mortality to the 3 to 5 month olds. Comparing less than 3 month olds to the oldest cohort, the 12 to 23 month olds, they had rates of head imaging at 50% versus 18%. And what you see there to the right is the confidence interval surrounding the difference between those two numbers. For any traumatic brain injury, 17.5% versus 2.7%. For clinically important traumatic brain injury, so either with death, with surgical intervention, or with need for hospitalization for 2 or more nights, so not just a sort of transient overnight observation, it was 4.6% versus 0.5%, and of death was 0.3% versus 0.1%. So our take-home points here are that infants less than 3 months are significantly more likely to undergo cranial imaging. And though this is sort of a moment in time that we're all really being pushed to be very thoughtful with our radiation, and that is appropriate, I think the study does really show us that this higher rate of imaging is likely justified in this population, as they have a higher rate of clinically important TBI and more likely to suffer mortality. I think it's also just worth noting that infants 3 to 5 months also likely merit some special degree of consideration, with similar, though overall low, rates of mortality and also significantly higher rates of CI-TBI than the 6 to 11 and 12 to 23 month olds, so that wasn't the primary focus of the study. All right, moving on, sticking with the theme of trauma for the moment. So I had referenced the PCARN head injury rules, which I think is far and away the sort of most well-known of their studies and their prediction rules. They have now a new prediction rule for cervical spine injury and trying to determine children who may be able to safely avoid C-spine imaging in trauma. So looking at this, it was a prospective observational cohort study across 18 specialized pediatric emergency departments that sought to create a clinical decision rule regarding the need for C-spine imaging. They evaluated all patients 0 to 17 presenting with blunt trauma, and they divided the group into derivation and validation cohorts by ED. They completed prospective surveys regarding symptoms, exam findings, and C-spine risk factors by that patient's attending prior to any review of imaging. And their outcome was C-spine injury within 28 days of visit requiring inpatient observation or surgical intervention. And they then applied the decision rule to see the potential effect on rate of imaging use. So they had about 22,000 patients enrolled, divided somewhat equally between derivation and validation cohorts. Of this group, about 2% had a confirmed C-spine injury. They identified risk factors as sort of high risk factors and non-negligible risk, which we'll review in another slide. And they combined them to create a prediction rule. With these together combined, it had 94% sensitivity, but 99.9% negative predictive value, with about 60% specificity. And they found that the application of the prediction rule in this cohort could have created a potential reduction in the CT utilization from about 17% of patients receiving imaging to about 7% of patients. These are the factors that they took in mind. Certainly nothing on the left is at all surprising. The high-risk factors are quite high risk, significantly decreased mental status, abnormal airway, breathing, or circulation, or focal deficits. The non-negligible risk factors, as you see there, are also somewhat predictable in what they would be, but again, not such absolute risk. So midline neck tenderness, having substantial head or torso injury, having reportive neck pain, or having slightly decreased mental status. So the take-home points are, again, a lot of this is about awareness, for you to be aware that there is a new C-spine prediction rule available for your consideration. That may help us safely reduce the patients in whom we obtain C-spine imaging, but certainly further study in the community ED setting and additional validation studies may be warranted. All right, PCARN gets one more. So we have referenced already the PCARN head trauma rules for both under 2 and 2 and over. There also are PCARN blunt abdominal trauma decision rule. There is a decision rule that is one for all age groups. This is a study that sought to perform external validation of each of those rules. And they essentially sort of did them together, I think, for optimal use of resources. And so let's take a closer look. This is a prospective validation study enrolling patients 0 to 17 at 6 EDs from 2016 to 2021. There were 3 distinct cohorts, so the under 2 with isolated head injury, 2 and over with isolated head injury, and 0 to 17 with blunt abdominal trauma. Their head injury outcomes were, again, as previously defined, death, surgery, I didn't mention previously, intubation greater than 24 hours, or hospitalization greater than or equal to 2 nights. The abdominal injury outcomes were death, surgery, embolization, transfusion, IV fluids greater than 2 days. CT imaging was obtained at the attending's discretion, and patient factors were analyzed by each existing clinical decision rule in parallel. So essentially, like, clinicians did what they wanted to, but then they saw in the decision rule what might have been possible. You can see for the abdominal injury cohort, they had about 7,500 patients, and the rule performed with 100% sensitivity and negative predictive value, with similarly high performance for about 5,500 patients with head injury under the age of 2, and about 14,000 patients with head injury over the age of 2. And so the author's conclusions here were a little bit sort of stronger than the prior studies, which is the PCARN head injury and blunt abdominal injury decision rules have now both been validated with a high degree of accuracy, and their utilization in emergency department care can now be considered a safe strategy for providing appropriate care to patients while minimizing unnecessary imaging. All right, with that, I'm going to hand it over to my colleague, Dr. Mortari.
Hello, everyone. So I'm going to continue with the trauma theme, and I'm going to talk about low-value clinical practices in pediatric trauma care. This was published in JAMA Network Open. This was a study out of Canada, and what they were looking at were what low-value practices or practices where the potential for harm exceeds the potential for benefit are present in pediatric trauma care. And there have been other studies that have mostly looked at adult trauma care, but this one really focused on pediatric trauma care. And so they identified practices they found 19 of them based on systematic reviews of CPGs or clinical practice guidelines in 2023. To give you an idea of what these low-value practices were, 11 of them, or 58%, pertain to diagnostic imaging, 1 to fluid resuscitation, 1 to specialist consultation, 2 to hospital admission, 1 to ICU admission, 2 to management of solid organ injuries, and 1 to DVT prophylaxis. So kind of a range of different things they were looking at. So this was a retrospective multi-center cohort study in Canada and Quebec, and it included all 16-year-olds and under that were admitted to any of the 59 provincial trauma centers from 2016 to 2022. This is a mandatory registry for all admitted trauma patients. They looked at the incidence per 1,000 cases. And so to be categorized as low incidence, it was less than 10%, as well as less than or equal to 10 total cases per 1,000. Moderate was greater than 10% or greater than 10 cases, and high was greater than 10% and also greater than 10 cases. They also looked at inter-hospital variation using an ICC because they wanted to look at practices where there's truly a lot of variation, because these might be places where interventions might especially be valuable. And so they defined low variation as less than 5%, moderate 5 to 20, and high greater than 20%. In total, they had over 10,000 patients less than 16 who were admitted for an injury to a trauma center. The average age was about 7 years, and 41% were girls. The most common mechanisms were fall, and then you can see the blunt object trauma, MVCs, and much fewer were non-accidental trauma or abuse. And extremities were the most common injuries, excepting in the less than 1-year-olds, where there was a high percentage of head injuries. And the vast majority of these patients were hemodynamically stable with a GCS of above 13. And they found that of the 19 low-value practices, there were 5 that were moderate to high frequencies and also moderate to high inter-hospital variation. And these were getting a head CT in low-risk children, and you can see the percentage as well as the number of cases per 1,000 and the interclass class correlation in the percentage there. The next was pre-transfer CT in children with a clear indication for transfer. Then it was neurosurgical consultation in children without a clinically important intracranial lesion. Then the last 2 had to do with hospital admission. So hospital admission in isolated mild traumatic brain injury, and then hospital admission in isolated minor blunt abdominal trauma. So this study highlights specific targets for interventions to decrease low-value care in pediatric trauma patients, and really categorized into the imaging categories, certain consultations, and admissions. I'm going to move on from the trauma category to a new category looking at racial and ethnic disparities in child abuse identification and inpatient treatment. This was also in JAMA Network Open. This was a retrospective, multi-center, cross-sectional study using the KID, or Kids Inpatient Database, which is the largest publicly available all-payer PEDS inpatient care database, and included all patients less than 18 who were admitted for a trauma indication from 2006 to 2019. And so they looked at these patients, so anyone admitted for trauma, and extracted data on patient demographics, included race and ethnicity, age, sex, insurer, payer status, socioeconomic status, injury severity scores. And they also looked at hospital characteristics and hospitalization characteristics. So that included length of stay, the size of the hospital, the region of the hospital, the type of hospital setting, like rural or urban, and they also looked at the hospitalization cost. They then looked at all trauma patients and then compared that to the subset of with children with suspected child abuse. So in total, they had about 620,000 children admitted for trauma, and then they had 13,000 of those who were admitted for suspected child abuse, abbreviated SCA here. The mean age of the suspected child abuse patient cohort was 1.7 years, and 56% were male, and you can see the racial breakdown on the screen here. For the non-suspected child abuse group, the racial and ethnic distribution was actually similar and not different from the 2010 US Census data. But when they looked at just the suspected child abuse cohort, Black and Hispanic patients were overrepresented. After controlling for the patient demographics as well as hospitalization and hospital characteristics, they found that Black race was an independent risk factor for suspected child abuse, and you can see the odd ratio there, whereas Hispanic race actually became, and ethnicity became a protective factor for suspected child abuse. So the take-home points from the authors were that Black patients were more likely to be suspected of experiencing child abuse compared with white patients. They actually looked at the median illness severity scores and mortality rates, and they had similar of those. Younger patients as well as lower SES were also more likely to be suspected. So they felt that standardized screening tools might likely be helpful in addressing these disparities. On the subject of disparities of care, there were two interesting articles that we did want to briefly touch upon. One that had to do with behavioral health patients and another with behavioral flags in pediatric patients. So the first one was on race, neighborhood disadvantage, and pre-hospital law enforcement handcuffing in children with behavioral health emergencies. So this is a situation where EMS is called, police are also called, and it ultimately ends up in the child being handcuffed while being brought into the ED. And so this study was done in Alameda County in Northern California using the ALCO EMS database. They looked at information from 2012 to 2019. There, they had about 6,700 pediatric behavioral health emergency encounters, of which 7.6%, so that's about 500 cases in this time period, had handcuffing. And when they looked at the breakdown, they saw that Black children were almost 2 times as likely to be handcuffed, and Black females, interestingly, were more than 2.5 times as likely to be handcuffed as white females. And then children from disadvantaged neighborhoods were also 1.5 times more likely to be handcuffed. And they kind of broke it down by moderate disadvantage versus high disadvantage. And so again, I think this is interesting when we see our patients, especially our pediatric patients, coming in handcuffed to think about this data, as well as there's recommendation for standardization of EMS protocols as well as police protocols for taking care of these children with behavioral health emergencies. This was an interesting study looking at the application of behavioral flags in hospitalized pediatric patients. I think we've all taken care of patients where we see like a behavioral flag pop up. And so this was specifically for hospitalized pediatric patients at one academic institution with 2 pediatric sites from 2012 to 2021. And then behavioral flags can be placed, in the study, they were placed for anything from witnessed substance abuse to history of inappropriate behavior, needing security, violent behavior, dismissal from practice, and CPS holds as well. And they extracted data on race, ethnicity, insurance status, as well as primary language. Of the 55,000 total patient encounters, over 200 had behavioral flags, and Black and African American patients were 2 times more likely to have that placed. Interesting, the younger they were, the more likely. So the less than 1-year-olds were 3.5 times as likely to have it placed, and the 1 to 7-year-olds were 2.87 times as likely. Because the flags can be placed for family versus patient, likely in the very young children, these were probably placed regarding the family, the Black, as opposed to the child. They also found that patients with government versus private insurance were 2.6 times more likely to have them placed. So definitely more research is needed on how these flags actually affect the patients and their care. But I think as we see those behavioral flags, it's important to reflect on them and all the various reasons why they might be placed on a patient. And then my last study, I'm gonna switch gears and talk about the BRUIs and the epidemiology of brief resolved unexplained events and the impact of the clinical practice guidelines in a general and pediatric ED. So you may all recall we used to have ALTs, apparent life-threatening events, and then they became BRUIs, or these brief resolved unexplained events. And in 2016, a clinical practice guideline was released that really emphasized against routine diagnostic testing, though health providers could consider obtaining an ECG and pertussis testing. And then it also advised against routine hospital admissions for these patients. So in this study, they looked at a large national database, the nationwide emergency department sample of patients less than 1, which part of the definition of BRUI is that it occurs in a less than 1-year-old, who were diagnosed with a BRUI, and they wanted to describe the incidences of BRUI as well as assess the impact of these clinical guidelines on specifically EKG attainment and the disposition. And they compared pediatric-specific emergency departments to general emergency departments. So they compared before the CPG in 2016 and after. So there were over 130,000 visits for BRUI that were identified. 80% of these occur in general EDs. So the vast majority of children presenting for BRUI are being taken care of in general EDs. And the incidence was unchanged across the study period, so there's not more or less BRUIs occurring. But they did find a significant difference in rates of EKG attainment before and after the study, specifically in pediatric EDs. So there was a 13% rise in pediatric EDs, whereas pretty unchanged in general EDs. And then they found that the rates of either admission or transfer, basically for admission if your spot did not admit patients, decreased in pediatric EDs. So prior to this, both the rates of admission in pediatric and general EDs were in the 50s, like 50% range. And in pediatric EDs, it decreased by 23%, whereas in general EDs, it really remained unchanged. And so there is definitely more of an impact of the CPG guidelines on pediatric EDs compared to general EDs. So their take-home points were BRUI remains a common problem, and 80%, so the vast majority, are seen in general emergency departments. But the BRUI clinical practice guideline has had variable uptake and really has not modified care in the general emergency department setting. So this could be a potentially high-yield area for targeted quality improvement efforts.
All right, so I'm going to talk about some articles related to infectious disease. So the first article I'm going to talk about is accuracy of screening tests for diagnosis of UTI in young children. And I feel like this is coming up more and more. A lot of institutions are starting to use urine analysis with reflex culture. So that means depending on what the urine analysis looks like, the lab will decide whether or not they will do an automatic urine culture. Some places, people still have to order the urine culture and urine analysis separately. So this is actually coming up in our institution. Are we ordering too many urine cultures? So I was actually very interested in this article. So this study looked at children aged 1 to 36 months. They all had a cath urine analysis for suspected UTI. This was done at 3 pediatric hospitals, and they defined a positive urine culture as having a pathogen of at least 50,000 CFUs. They excluded patients who had immune deficiencies, any GU abnormalities, and if they had been on antibiotics recently. So out of 4,100 children, 81% had fever within the past 24 hours. About almost 10% had a positive urine culture, and the mean age was 12 months. So when you look at the sensitivity and specificity of these different aspects of the urine analysis in febrile children, so leukocyte esterase was not very, it's pretty sensitive, 84%, but more specific at 95%. Pyuria, I have a range because each hospital uses a slightly different way of measuring pyuria. Some of the hospitals use a manual differential, others use the automatic, and then there's also flow cytometry. But pyuria is 75 to 90% sensitive, and specificity 85 to 92%. And the most sensitive way to look at a urine analysis was the combination of pyuria plus bacteriuria. That was very sensitive, 95%, but not very specific at 71%. So what does this mean? This means that, febrile children under 36 months who have a cath urine, you should probably send a urine culture, because if you look at these numbers, I called out pyuria specifically. If you had a urine analysis that had no pyuria, 20% of those will actually end up with a positive urine culture. So something to consider when you think about these children who are getting a cath, because it's very hard to recath later with the parents. All right, this next article is interesting. It's a very small article study, but we found it very interesting, and it may change your clinical practice, so we included it. So this one looked at probiotics and fever duration in children who have upper respiratory infection. And this was a randomized clinical control trial. So they triple-blinded people, so the parents, patients, and physicians were blinded. And then the intervention group received a probiotic mixture, so it was either probiotic drops or sticks, depending on how old they were. They took this once a day for 14 days. The placebo group received a similar mixture that they also took for 14 days. This occurred in a pediatric ED in Italy. So they looked at children ages 28 to 4 years old who had a fever and diagnosed with an upper respiratory infection in the emergency department. Parents were asked to check temperature 3 times a day, and then they received a phone follow-up appointment 7 days later. And if they continue to have fever, they would have subsequent phone appointments. So they excluded patients who had diarrhea, recent probiotic use, any autoimmune diseases, immunosuppressants, or hospitalizations. And then the outcome they were looking at were the number of days of fever. So they enrolled 128 patients. Average age was 2.5 years. So they did intention to treat analysis. So half the group went into placebo, half into probiotics. And what's interesting is that the placebo group had fever duration about 5 days, whereas the probiotic group had fever duration of 3 days. So this means that with the adjusted risk ratio of 0.64. And they actually found very minor side effects with the probiotic use, a little bit more constipation in the probiotic group and a little bit more abdominal pain. But these numbers were very small, so I wouldn't really say they're clinically that significant. So interestingly, I think considering use of probiotics for fever, for febrile children who have upper respiratory infections might help reduce their fever duration in the future. So something that may change your practice. All right, and this last infectious disease article we're going to talk about is validation of hospital for sick children algorithm for discriminating bacteremia versus contaminant in children who have a prelim positive blood culture. So I think we've all been in that situation where we've had a positive blood culture on a patient that we've discharged, and we're trying to decide, do we call them back? Is this really going to be positive or contaminant? Because studies have shown like up to 40 to 60% of blood cultures are actually false positives. They're not true positives. So what they did was they looked at a retrospective cohort of children with a positive blood culture at a tertiary pediatric emergency department. They looked at this algorithm they started to use afterwards. So in the very top box, they're looking to see if this is a high-risk patient or not. So if you had a patient who had a gram stain that was positive, they were immunosuppressed or less than 3 months, then you would call them back to say, you need to come back, get IV antibiotics, and admitted. And if they didn't have any of those risk factors, then you look at the second class, which would be considered moderate risk. Do they have a central line? Do they have chronic illnesses like kidney disease or rheumatologic illnesses? And those patients, you would want them to come back, and once you send a second set of blood cultures, you would reassess and decide whether or not they would need antibiotics. And the last group is the low-risk group in the green box where, they're generally well, healthy children. These are the kids that you would just do a phone call, and if they don't have a fever, they wouldn't need to come back to the emergency department, and you could consider looping in their pediatrician to help with the follow-up plan. So they looked at 375,000 visits, ED visits, and out of those, they found 29,000 patients who had who had blood culture sent, and out of those, 574 had a positive blood culture. So this incidence rate is pretty accurate. 1 to 2% is what most people are estimating that the true positive rate of blood cultures are. And as you can see, the study kind of confirms that half of them will be contaminants. The median age of this cohort was 24 months. The most common pathogens were Staph aureus, E. coli, and Strep pneumoniae, and the most common contaminant was Staph epidermidis. So when they apply the algorithm to all of these patients, in the initial cohort, what they found was that 2 patients actually got discharged without antibiotics who ended up growing staph on a second blood culture. So then they were like, okay, if we apply this algorithm, would those 2 patients have been discharged, or would we have kept them in the hospital? So when they looked at using this algorithm on this cohort, they would have divided about 63% of them into the high-risk category, of which 62% were actually bacteremic. 31% would have been categorized as medium risk, in which 33% became bacteremic, and the low risk group would have been very small, 5.6% with 0% bacteremia. So this algorithm is very sensitive, so you probably will not discharge, you will not miss true bacteremia using this algorithm, but obviously not very specific. So they looked at predictors for bacteremia. So if patients have suspicion for any osteoarticular infection, any internal hardware like central lines, a gram stain that was positive in pairs or chains, if they traveled outside of the US or Western Europe, or if they have a gram stain that's positive within 16 hours, those are kind of more predictors of a true positive. So I think take-home points are, 50% of prelim blood cultures that come back positive end up being contaminants. So this algorithm is a way that you can kind of manage these positive blood cultures in your emergency department to figure out, do you need to call them back? Do they need to be admitted? Should they be started on antibiotics? All right, and now the next couple of articles, we're going to switch into kind of more innovation. So this is a very interesting study because what they did was they used an infrared camera to figure out whether or not you can use an infrared camera to look at long bone fractures. And the idea behind this is that when you break a bone, you set up this inflammatory response with increased blood flow, so theoretically there's increased heat in that area. So this was a very small pilot study where they used this small infrared camera that attached to an iPad, so pretty doable. And then they worked in a pediatric emergency department looking at children less than 5 years old who they thought, okay, we think they have a long bone fracture. So they used two different imaging algorithms. They excluded children who had an injury for more than 24 hours if they had ice or heat on the arm or any topical medication or splint placed in the past 3 hours, because that would affect the temperature, and then whether or not, if they had a fever, osteogenesis imperfecta, or osteopenia were also excluded. So in this small pilot study, they enrolled 31 patients who they thought, okay, we think these patients have a fracture. Ultimately, 77% did have a true fracture on X-ray, and 22% had no fracture. And then the infrared camera identified fracture 92% of the time. So this is kind of interesting new tool that could be used in the future with more validation. So I would say take-home points here is this is a very small pilot study which showed that it's feasible to use this thermal camera attached to an iPad to identify fractures. But the biggest limitation in the study was that it takes about 10 minutes for this thermal camera to do the reading. So it's very hard for a 5-year-old to sit still for 10 minutes, especially with a broken arm. So I would say feasibility, that's kind of limited, but, and the other thing is this lacks FDA approval. This article, this is a research letter that was recently published about FDA approval of AI and machine learning algorithms. So the FDA requires all AI machine learning algorithms that are used on patients to go through FDA approval. So this group looked at the approvals from 1995 to March 2024, and they found that 876 medical devices who use AI or machine learning were approved during this time frame. Most of them were used for radiology. Second most common use was cardiology and then neurology. But only 17% were actually labeled for pediatric use. And interestingly, the FDA has a definition of less than 22 years of age as a pediatric patient. But the authors were trying to use less than 18 as a true definition of what a pediatric patient should be. And then half of these devices didn't even mention whether or not it should be used for children or not. They just kind of left it unlabeled. So a very small number of devices are actually tested on children or authorized for use in children. And I think the FDA has several grants across the country where they are trying to increase the number of pediatric devices to be validated. So something to consider if you're looking for research funding, look to the FDA. They have like all these pediatric device consortiums across the country to think about. All right, and the last article, of course, we have to talk about ChatGPT. So this article was recently published looking at the power of using ChatGPT for clinical summaries for the attending physician. Basically, what they're trying to do is figure out, like, does this save time? Does it save your effort? And what's your attitude to using ChatGPT? And what are some potential risks and barriers to it? So they asked 10 pediatric emergency medicine physicians to write 4 notes, assuming that the resident has already seen them. And now you're supposed to write 4 notes. We want you to write 2 with ChatGPT, 2 without ChatGPT, and then we're going to measure how long it takes you and what you feel like your effort was. So overall, what they found was, well, they had 4 cases. 2 were very simple, like asthma and gastro, and then 2 complex cases, like fever of unknown origin. And so what they did was they found that when they asked attendings to complete their note, it reduced their time by 40%. And then the accuracy, efficiency, and readability were pretty good. And they felt like it decreased their effort by 33% for the more complex cases, but no real effort change for the more simple cases like asthma and gastro. And most of the participants seemed to favor its inclusion. I think some of the concerns they had were, how do we make sure this is a HIPAA secure space, because they had created this fake patient that they used ChatGPT. I don't know if your institutions have this, but we actually have a specific ChatGPT to be used just with patient care. So it is a secure platform, which is good. So that's kind of one barrier that I think a lot of hospitals have reduced. So I think overall summary is that, pediatric emergency medicine attendings perceive ChatGPT to help deliver high quality summaries, which save time and effort, but in more complex cases, but not necessarily in the more simple cases. All right. That's the end of our slides. So if you guys have any questions, we'll be happy to take them. Thank you for staying and listening. We appreciate it.
First, that was truly helpful, so thank you for all the time and effort for that. I have 2 questions about the head injury. One, that I was humbled by the less than 3 people and the major findings. Did the study talk about, were these surprise findings, or were there other clinical things that would suggest this remarkable traumatic brain injury?
Yeah, thank you so much. Great question. I also was humbled by those results. The study was from, if I'm keeping them straight, was from the FIS database, I believe it was. It did not have data on, was there a large hematoma, for instance, large like non-frontal hematoma that would sort of fail the PCARN rules. So no, I don't have that degree of data, but I do think it's worth noting that even when you do have something visible like that, you're still sort of possibly allowed to pass the PCARN rule, just observation. And so where they had previously had that, just consider less than 3-month caveat, I think we just have a little bit more data on maybe how strongly to consider that age group as a decision making as we observe or image.
And then this other study that looked at low yield practices, one of them being consulting neurosurgery for insignificant. How is insignificant? It sounded like you could have a positive CT finding, but it's not significant to the neurosurgery. Is there more specificity to what qualified as a positive finding, but not significant enough for neurosurgery consultation?
So they use the typical criteria for a clinically important traumatic brain injury. So these were felt to not require a 2-day hospitalization, not need surgery, not have mortality or those kinds of things. So for that, they didn't within those because it was a large database of all inpatient admissions, they weren't able to go down into specifically which patients had what. So not exactly for your answer, but they were felt in general. It was felt that these patients were not going to need a neurosurgical intervention or follow up, and so that was felt like it wasn't needed to have the consultation.
Not straight from that study, but one thing that comes to mind is I'm yet to get my current facility to not consult neurosurge for non-displaced linear isolated skull fractures without concern for NAT. I think that one pretty much everybody can agree is low value. So that's one thing that comes to mind, not straight from the study, but.
So, one kind of joke and then one serious question. So is it rude or rude?
Dealer's choice.
Okay. Literally on rounds 2 days ago, someone was asking, I think this is it rude. Okay, the C-spine, I find it the PCARN for head injury, oh my God, it's the greatest gift,
Yeah.
The C-spine one,
Yeah. Yes.
Tenderness, pain, kill me.
Yeah.
So when they say there's a reduction, they introduced, I feel we've converted. We went to CT, and then it was maybe there's an X-ray. You got an X-ray in some cases. But I still feel okay, I'm still stuck with this, very low percentage. I was hoping, and honestly, I've done a little research on this, and I stopped it.
Yeah.
Because I can't come up with a decision that's truly based in data.
Yeah.
That's
100% agree. There's no way that we could give like what's like new and like large studies and potential practice changing in PEM literature without including any major PCARN study as like our primary research network. But I agree. Whereas the PCARN head injury study was like a gift from whatever you believe in. And the abdominal injury study I actually think has some significant value that is maybe underutilized. The C-spine, we just, as we rehearsed yesterday, we were talking through it. I may not have done it total justice. I didn't clarify when you sort of look at the study, or there's an MD Calc based out of it, so when you punch it into MD Calc, if you put in high risk factors, like the really concerning features, it will recommend a CT. If you put in the non-negligible risk factors, it will recommend x-rays. So that's at least sort of trying to spare the CTs, and certainly if you have some large fracture with like retropulsion, you should see that. But it's still, of course, not fully sensitive or specific for significant injury. And so, if you're at an academic site, then like, I guess worst case scenario, you're stuck like waiting for an MRI for the ligamentous injury. But if you're in the community, like it's a transfer or not, and I agree, it still feels like you're a little bit stuck. I'm hoping that was the initial publication. Technically, all they might be planning to do is like additional external validation studies, but I'm sort of hoping that maybe in that process they also try to make something that's a little bit more like stepwise. And then what? When your X-rays are negative and you still have midline tenderness. Totally agree.
And I will say there has been a nice progression of the PCARN C-spine studies where before they were really like anyone with any neck pain ever, we just can't say you're low risk. So then everyone just started CTing all the children with maybe they had some neck pain. And like I think the specificities were like 11%, 12%, at the really young age, it was like 27% in the slightly older age. Yeah, so there's that unintended consequence. So I feel like this study does give you a little bit more and has better like sensitivity specificity characteristics as well. But I do think we would hope that there will be like even more. But it's just a really tough group. Like the C-spine is really hard. Yeah.
But I think your point is well taken. I had like academic center mind focused on it, and it was like, come on, like I'm having someone wait for an MRI, like it's taking a day to have it done. And but when I speak to the neurosurgeons, I'm like, I'm just gonna send them home. And they're like, who's gonna clear them? And they're like, pediatrician. I speak to the pediatrician, like,
No, we're not. Yeah.
Person's like, we're too busy. Don't send it to us. I'm like, okay, I guess they'll stay 24 hours.
I know, it's brutal, and that's even like in the easier setting of having the MRI available. I'll confess that it's not been as like zero incidents of the parents and the guy just don't want to wait, I want to go home. I'm like, okay, we have to wear a collar. They're like, I don't think he's going to wear it. I was like, well, he needs to wear it. And then you kind of know they take it off in the parking lot, and you kind of know you feel okay with that. But like you've done what you need to. Obviously, in very select cases that you're sort of trying to follow the rule but have low actual, in your heart suspicion. Other questions or comments?
The probiotic studies.
Yeah. It was very interesting, yeah.
Two questions. Was there any discussion of the mechanism why? And second question, I don't know if Italian probiotics sort of superior, the way the cost is superior, but like, was that a special formula with a special percentage of different?
Yeah, it looked like it was just over the counter that you could get it. You didn't need a special prescription. It was just over the counter. It was like the most commonly available probiotic in Italy. And it also talked a little bit about, do these probiotics reduce the cytokines in your body? And maybe that's why there's less fever duration. It was very interesting too, because I was like, this is such a small study. And then actually the adherence to the intervention placebo wasn't great. It was only but they did a sub-analysis of the patients who actually did follow the intervention. And even then, it was still significant. So we decided to include it so it was kind of an interesting study. In the article, they do list out the exact names of all the different probiotics that were in it, but I couldn't read them all off.
I'll confess, I think like the non-parent of the group
Yes.
was like, and the two parents were like, no, 2 days without fevers.
Yeah, that's a big difference for the kids, yeah, from us, yeah, from missing work, daycare, yeah.